Okay, I can see we have quite a few people already in, so we can get started. Welcome to IGHI's Global Health Forum on responding to COVID-19 through innovation. My name is Nikita Rathod. I am a Communications and Events Officer at IGHI. Before we get started, please can I ask all attendees to ensure that their mics and cameras are turned off? And this is just in case, we get outside interruption. So please just make sure that is on. Our second Global Health Forum of this year. The forum is a platform to bring together Imperial researchers, students and staff from across all of Imperial's faculties to highlight, discuss and disseminate findings on current research and innovations on global health topics. The forum takes place on a monthly basis and it's been running for quite a few years now. We will be live tweeting throughout the event. We encourage people to get involved in the conversation on Twitter using the hashtag IGHI Forum. And our Twitter handle, if you're not already following us, please do, is @Imperial_IGHI. So here at IGHI, our researchers have been working on a number of innovative projects since the COVID-19 outbreak to support policymakers, health systems, patients, and those who are working on the front line. These projects have required quick thinking to ensure that they make an impact. So today's forum is part one of our responding to COVID-19 through innovation, where we get to learn more about some of the unique projects that have been born out of the pandemic. We have three great speakers here with us today who are going to tell you about three very different projects. And they will speak back to back, and then attendees will have a chance to ask the speakers questions. So if you have any questions that come to mind whilst our speakers are giving their presentations, please feel free to type them in the chat, and then I will pick them up at the panel discussion after all three speakers have spoken. So I'm going to introduce you to our first speaker, who is Dr. Fahad Iqbal. He is a clinical research fellow at the Department of Surgery and Cancer in IGHI, and he's going to be speaking on remote monitoring used in suspected cases of COVID-19. Fahad, if you could just please share your screen.
Is my screen visible?
Yes, that's great.
Great. Thank you, Nikita. So, as Nikita said, I'm Fahad. I'm currently doing a PhD in wearable sensors under Prof. Darzi. So this work was brought about by seeing if we could use wearable sensors to assist with remote monitoring in people we suspected to have COVID-19. And this essentially is a pilot proof of concept study that we came up with. Thankfully, the media has given us a lot of the background already, so we all know COVID is bad, so I don't need to go too much into that. But vital signs are quite good. They're what we use to provide a fundamental component of clinical care, whether that be in hospital settings, nursing homes, or even rehab step-down centres as well. One way in which we standardise this across the country is through early warning scores. And these essentially dictate what vital signs need to be recorded, how frequently, and what to do if we pick up any prodromal deterioration signs. And overall, these have been quite positive. But one of their big limitations is that performed very intermittently, normally every 4 to 6 hours, or at least so in theory. In practice, given the busy work schedules of everyone, they tend to be performed even more intermittently than that. Now that leaves a window where acute deterioration can be missed. So that can have potentially catastrophic events for patients. Where wearable sensors come in, and this is just one example, this one's made by a company called Sensium, is that they can provide continuous monitoring. This one in particular attaches to patients with ECG electrodes, and you can see, you can just kind of at the edge of the picture, there's a coiled wire that we kind of taped into the axilla, which measures temperature. This is a waterproof, disposable sensor, so once you're done, you can just get rid of it, and it's got a reasonable battery life. Now, this measures heart rate, respiratory rate, and temperature continuously, but it's also got quality control checks built in place. So what it can do is, within the algorithms, if it picks up irregular or noisy signals, it tends to discard them until the next cycle of observations go through. Once it's recognized and picked up those vital signs, those 3 that it measures, it can transfer them either to a mobile app or to a secure web portal on a computer. And the advantage of that is once it picks up a pattern of deterioration, it can alert the viewers itself. The principle really is that it picks up acute deterioration earlier because of the continuous monitoring, getting more frequent monitoring of vital signs, and that gives a window of intervening more rapidly than in traditional methods. So here you can just see a schematic of it, but the aim of this kind of study was to determine the use of this sensor and provide a new model of healthcare delivery in a hotel setting for individuals we suspected to have COVID-19. This is kind of a very new trial. So the idea here really is to focus on what individuals felt in terms of how the device sat, what the system was, how user-friendly it was, any kind of safety concerns, and what data we were really getting. And that would then establish further trials. So the way this was set up is it was a couple of hotels near Heathrow Airport over approximately a 6-week period. And there was a central monitoring hub which contained nursing staff, London Ambulance Services, security porters, virtual GP access, all 24 hours a day. And they would be able to view all the vital signs that were going and plan accordingly. In terms of our inclusion criteria, initially it was all flight arrivals that were coming into London airports with people who we suspected to have kind of mild COVID symptoms. Eventually flights were all grounded, so that meant that our inclusion criteria would have been nothing. So we ended up adding on any healthcare staff that were symptomatic but had to shield away from home. So they were also included. The only people we really excluded were those with pacemakers, and that's because of signal interference with the patch. Now, the duration of isolation in terms of how long they were meant to stay in the hotel varied considerably. That really was out of our control and more to do with the government changing their guidelines. The duration of isolation really depended on if they were an NHS worker or not, what their swab results were, what their symptoms were, and whatever their guidelines were at that particular moment in time. We did want to measure some outcomes. Initially, what we're really trying to see is how feasible this kind of study would be. But we also wanted some brief data on what number of alerts were being generated, what the clinical outcomes were. And we used an adaptive scale just to see what was the usability and overall acceptability of the system. Now, the way that the hotel was set up is that these bridges are essentially, think of them as Wi-Fi routers. They plug in and they essentially allow communication between a sensor to either a mobile phone or the computer. These are then displayed on a big TV screen that they had in the central monitoring hub, along with another screen which had flight arrivals coming in and shows all any deteriorations or alerts that were being sent through. The way the alerts were generated were essentially tailorable, but through pilots based at another hospital that we've been doing some work with, and that was over a cohort of about 500 people, a window of 10 minutes with those particular parameters. So if individuals had respiratory rate over 25, heart rate over 131, and temperature over 38, persistently for 10 minutes, that would cause an alert to be generated. This has been trialed with various other kind of alerting windows, and it was found that this was good in the sense that it wouldn't give too many false negatives, which wouldn't result in alert fatigue for healthcare professionals who are actually viewing it. That work was actually done by one of my supervisors currently. So coming to the results, given that we only had a 5-6 week period, we got a total of only 14 individuals. But despite that, there's quite a nice mix in terms of age, ethnicity, and as well as gender. So it's a fairly balanced spread. We also had some individuals with comorbidities, but most didn't. Looking at our outcomes, roughly 10 vital alerts were generated across 4 patients. Most of these were for abnormal respiratory rates, and most of them resulted in no action. One of them required electrode replacement. There was also an alert generated for an abnormal temperature, which did result in some administration of paracetamol. In terms of the management, this was protocol driven. So any vital alert that was generated will result in telephone contact between a nurse and one of the guests that was staying in the hotel. Obviously, with all hotels, they have phones built in, so there wasn't any need for clinical face-to-face contact. 2 of the alerts, unfortunately, remained unactioned, and they expired for abnormal respiratory rate. But individuals required any escalation to hospitalization or even virtual GP review. Talking about some of the safety concerns is that the adhesive tape that we use, which is micropore, and also some of the ECG electrodes, certain skins had some sensitivity to it. So they caused rashes and irritations. But none of the 14 that we had actually found that it hindered or that they wanted to stop wearing the patch as a result of that. So that was good to see from the fact that the sensor was actually pretty well perceived by the guests. Coming to some of the scales and the questionnaires we conducted, we found that actually, looking at our frequency distribution, the overall guests found that the sensor was quite comfortable. They didn't really find it a hindrance with their day-to-day movements, what they were doing. It wasn't a complicated thing, and they would be happy to wear it at home. Ultimately, that's where I see this going, where a lot of these individuals will be happy to wear sensors at home. We also wanted to find out what healthcare participants thought as well, and particularly the nurses. Here you can see a slightly more mixed response with some of the questions. Some of the main fears was that the model of healthcare provision within a hotel was actually perceived with some mixed feedback. Despite this, staff felt that the technology was quite good. It improved the overall level of healthcare that was there, and it was trustworthy. They trusted with the device and doing what it was meant to do. I guess the main fear for these nurses is if you have someone that deteriorates, you can't provide much healthcare in a hotel setting. And I think given this was during the first wave of COVID, this actually induces a lot of fear within the nurses. So if you detect deterioration, the idea is you have to send them into hospital, and you can't really do much in terms of an intervention point of view within the hotel. And I think that's probably what would explain that distribution. But coming towards the discussion, we did think that despite our kind of small sample size, we did manage to prove a concept that this was a pretty quick model that we provide of healthcare delivery, where a hotel acts as an extension to a healthcare trust. And there's a big potential reduction in viral exposure to staff as a result. Instead of having members of staff coming in, touching patients, we can perform routine observations remotely and quite accurately so as well. And overall, guests and staff members were quite happy with the whole system. There are, of course, limitations. We have quite a small sample size, and that means that certain outcome measures we can't really describe in too much detail. But again, as a pilot, this certainly served as quite a useful exercise to inform further trial design. We still need to optimize recruitment. Some of that is beyond our control and depends a lot in terms of what the government is saying with their local guidelines. But there is some further work still to be done. I have to say that this work wouldn't be possible without all of these people I've got a great team behind me who've managed to help me pull this trial together and some of my other work. So I have to acknowledge these guys. But thank you all very much for your time.
Thank you so much, Fahad. That was a brilliant presentation. And if you have any questions, Fahad, please do put them in the chat, and I'll be asking them during the panel discussion. So our second speaker is Mr. James Kinross, who is a clinical senior lecturer in colorectal surgery at our Department of Surgery and Cancer. And he's going to be talking about PanSurg, which is a global collaborative that was created during the pandemic. Over to you, James.
I think being on mute is a modern epidemic, isn't it? And I constantly seem to be on mute. Thank you so much for giving me this opportunity to speak. It's very difficult in 10 minutes to give you a detailed overview of what we've done, but I suppose if there's one take-home message from this talk, it's that if you give some of our lecturers, PhD students and clinical research fellows the room and the the means and the mission, they can achieve extraordinary things. And PanSurg really is testament to the tremendous work of a lot of people, and it's my privilege to present it, and I just put that at the forefront because a lot of this work has been done by others. So PanSurg was indeed a COVID response project. It was started and launched really on March the 15th after a particularly unpleasant week on call, when we acknowledged that what was happening was really going to have a really dramatic impact on surgical services, that our people were really unprepared for that impact, and that we needed to act very quickly, not just to educate them, but to understand what was happening and to innovate. And that's what we have tried to do. We very systematically set up PanSurg to be a communication vehicle. So we understood that digital component was going to be very important, and we very rapidly set up our own sort of flexible website and our own comms strategy, and Nikita and the IGHI team have been unbelievably helpful and impactful in that sense, because we knew that whatever we wanted to do, we had to be able to effectively communicate it. And it was immediately apparent as well that traditional research tools were simply too inflexible, too slow, and not suitable for what we were trying to achieve. The immediate challenge that we had in the first phase was education. It seems that if you go back to much, the word was a relatively underused word. It seemed like a quaint thing to do, and no one was really doing it. And here we are today speaking through the medium of Teams. But we very quickly moved to trying to understand in a very granular way what was happening on the ground in institutions and organizations ahead of the curve. So we very quickly reached out and started to set up a communication and educational forum for doing that. And we ran our first meeting on March 15th with some Italian surgeons from Humanitas Hospital in Italy, in Milan, and we subsequently run over 22 seminars now. We've had around 5,000 live viewers online with us, and from 54 countries. So we have a really global reach. Spoken through a number of different topics. We quickly understood as well that to understand what was happening, we needed some qualitative research. So we set up a number of different projects, and there's just too many to report here, and I'm not going to report them. But I just want to say that a lot of these initially were qualitative or I suppose survey-based studies looking at things as diverse as safety, training, and clinical practice, such as how we were changing cancer practice. And a lot of this work has been published elsewhere. But I'm just going to focus on 4 specific projects today, because these are going to be legacy projects for us. Importantly, Redassa Remote and PredictSurge, and we'll also talk about some of Johnny Clark's work. So what we knew when the pandemic began to really take hold was that elective services were going to be profoundly disrupted, and I'm sure you all realised it too. And we moved quite quickly to set up vehicles to try and measure what was happening globally. We knew that we had a digital healthcare record system at Imperial that we could leverage, but we wanted to get a better understanding. And really hats off here to Jasmine Winter-Beatty and Vic, who put in a lot of woman and man hours to set all of that up. So they were able to set up a REDCap database, and what we knew was that we needed granular data and we needed longitudinal data. And we were lucky enough to recruit 54 global institutions from 24 countries. We now have just under 6,000 patients recruited into that database, and it's still going, obviously, as we've had secondary surges. The initial objective with this project was to try and leverage that data to risk stratify patients in real time through, machine learning techniques. It turns out being very difficult to do, and one of the reasons it's been so difficult is because of the heterogeneity of the data that we've had. We're just now starting to get our first pass on that data, and that data is literally being analysed at the moment, and it's hopefully going to be ready for submission in the early part of next week. This gives you a flavour of what we're talking about. We get nice longitudinal data. So in the panel on the left, you can see it diagnostic approaches through the early phase of the pandemic, so through the first 27 weeks of the pandemic, and you can see how we've begun to rely on CT, chest X-ray, and imaging to make our diagnosis during those early 15 weeks. the pandemic, as we were really very unsure. And you can also see that the scale of the testing began to improve. And as we became more confident in our swab testing, we started to rely less on imaging to make decisions. And we can also look in the right panel on capacity. So we can look at ITU and HDU capacity, as well as operating and theatre capacity over time. The significance of that is that through Sam Mason's work, where he's looked at colorectal cancer practice, is it's this capacity which seems to be the most important factor in determining the level of elective services that we're able to deliver. So those hospitals who don't have resilience in terms of their ITU or HDU capacity seem to be severely effective in terms of their elective surgical practice. Of course, what we really need is actionable information. Johnny Clark and Alice and others have done some really very nice work trying to identify new models of healthcare that can help us address what we've called termed the surgical aftershock. So address the backlog of cases that we now have to deal with in surgery in the UK. This was a really nice piece of work where they looked at 7.8 million surgical cases retrospectively across 4.2 million patients. And what they were able to identify is that 50% of all of those operations are actually accounted for by just 28 operations, and that the majority of these patients travelling to those operations actually travel a very short distance. The furthest, I think, was around 15.7 kilometres for a removal of internal fixation of bone, or I may be wrong actually, I think it might have been a spinal injection, but it's not far, and the majority don't travel far at all. So if we use Markov modelling and a geographical model of the country, we can start to break down traditional boundaries of care, and we can start to group hospitals into new geographical variants of networks, and then model the flow of patients through that. And what we find is that when we redistribute these networks of care, we can start to better match the supply and demand, or I should say the mismatch of supply and demand, to improve patient flow through those models. And it has really quite a significant effect, as you can see in that table down on the bottom right. Johnny's just published that paper. It came out this week. We knew that from our educational conferences that there were a lot of competing ideas and concepts about how to best return surgical services to best practice. And so we compiled a one-day surgical symposium where we invited a number of different experts, and those sessions were open, and we performed a sort of qualitative pseudo methodology through a series of questionnaires and structured interviews to try and understand and map what was happening across the country. We've just published this report. It's available on our website, and we've made 14 separate recommendations. But there are a number of different common ideas that came out through this session, and the most important one was that it's now unacceptable to abandon elective surgical care in the face of further surges. This is not an unprecedented situation any further, and hospitals need to have enough resilience now to maintain our elective surgical practice. But we also need to significantly address major problems that we've had in the healthcare service, such as siloed healthcare working and our inability to adapt and innovate. And of course, there have been some tremendous examples of innovation in the face of COVID, but historically, perhaps, although we've been quite good at identifying technologies, perhaps we haven't been that good at adopting them. That report is out there and it can be read. So that was a kind of really practical attempt to try and understand what was going on. The third thing that we tried to do with PanSurg was try and innovate. And one of the most successful things we've done has been looking at mixed reality technologies. We ran a digital symposium the other week, and one of the conclusions from that was that there has been a rush to collaborate between industry and the NHS. And I think the next two examples, I'll show you are good examples of that. So for those of you that are unaware, the HoloLens headset looks like this. It's a wearable, untethered holographic computer. That's Louis, one of our care of the elderly physicians. He's very handsome. He's wearing that. And you can see it's got a camera in the middle of his forehead, and it's also got some sensors around the top of the headset. Microsoft came to us and they said, look, we've got this technology, can you use it? And we said, we're not really sure. This is at the beginning of March. But we took and adopted an iterative process. We said, look, well, there might be a role. And after going through several kind of potential applications, we settled on using mixed reality to reduce the burden of COVID exposure in clinicians working in COVID environments. Now, for some reason, my mouse isn't working, so I don't know if this video is going to play. So this is what the video looks. This is what it looks like in process. You can hear Louis speaking.
So the next gentleman is a 61-year-old male who's admitted as a major trauma call.
You can see that on the right panel, this is what the physician sees whilst he's at the patient bedside. So he can see heads up view of the registrar speaking to him. I'm just going to try and turn the volume down. Hang on, if I might be able to. Well, it looks like I've broken it, which is a bit annoying. When they're speaking, I'm sorry, the video's just broken. You're able to visualize electronic healthcare record data or X-ray data, and you can effectively run a bedside MDT, which is what that video goes on. You can see one of our respiratory consultants there, Claire, wearing that in an HDU COVID ward at the time. What we found was that we could significantly reduce the size of our ward rounds from around an average of a mean of around six clinicians, so doctors and allied healthcare staff, to 1. And of course, if you do that, you reduce the exposure to COVID environments, you reduce the amount of PPE you consume, and your efficiency of your ward round increases significantly by as much as 30%. In our busiest wards, we reduce the amount of PPE consumption by around 800 complete items of PPE. And hats off to Phil Pratt and Guy Martin, who did much of this work. But this doesn't seem to necessarily detract from a lot of the ability to communicate that clinicians have whilst they're wearing this headset. And in fact, some of our training doctors found that it significantly improved the ability of communication that happened about some of the sickest patients. And we've just published that data. Just in the last minute, I'll tell you about one of our other projects, which is looking at the infodemic. So we were very aware when we sat down at the beginning of the pandemic that there was a data tsunami, really, and it was very difficult to make sense of it. And we wondered about whether or not it would be possible to address this. So we were able to reach out to Amazon. And we had a discussion with them quite early on, and we said, would you be interested in helping us? And very generously, they said yes. So what we've done is we've developed a new methodology that uses basically web crawl technology. We point this at websites of interest, and it draws down and records data every week into a data cloud or a data lake that we have created. We now have the largest repository of COVID information, I think, anywhere in the world, and we have got something like 500,000 COVID documents now, which are all in text form and which can be interrogated. The important part is, of course, doing something with this information and making sense. So the big goal here, driven or a deep learning for the autonomous interpretation and synthesis of information in the cloud to answer very specific questions that we might have. And the way that we do that is with a human in the loop methodology or data curation technology, which is augmented by machine learning. And we spent the last few months building out that curation methodology, which is now live. And if you're interested in getting involved, you can absolutely get involved with us. Just very quickly, this is what it looks like. So the workflow on the left there shows you how the data pulls down information. So we can ask specific questions, for example, what time interval between SARS and what's the time interval between SARS infection and a positive test? That was a question at the beginning of the pandemic. We then have an intelligent way of pulling down that information from the cloud, so you get the targeted documents that you want. And we then have this UI interface, which allows you to label and annotate those papers as you go through it. You can then start to do things like validate according to checklists, and basically you get a granular data set upon which you can start to perform machine learning, and that's exactly what we've done. So we've set up specific curators. We've now had we're on our 5th different curation trawl at the moment. We've got over 200 data curators globally helping us answer and annotate questions from across the sphere, and this data set will go live, I hope, well, the plan at least is by the end of November, so that anybody will be able to come onto the system and use it and start to answer questions. And we're now seeking funding through the EPSRC. I'll just go through this because I'm talking a little bit too long, so I apologise. We've got about just over 5,500 documents now that have been annotated and curated, and that's only 20% of the entire global corpus of COVID evidence, and that's been done in just 4 weeks. So we think this is quite a useful tool and an application, and if you do want to get involved, please come to the PanSurg website or email me, and I'll happily introduce you to the team. These are some of our papers that we published that are referenced. I'll put this here, and I'll send you the slides at the end. And just to say, if COVID has taught us anything, it's taught us that people are our most important asset. It's been really great to work with these people. They're all fabulous, extremely committed and gifted academics, and it's my pleasure speaking to you. So thank you for your patience and your time.
Thank you so much, James. That was quite a whistle-stop tour.
Yeah.
And like, having helped out on it, I know how much work's been going on. It's been tremendous. Thank you for that. Last but not least, we have Sarah Jones, who is a PhD researcher here at IGHI, and she's going to be speaking on our COVID data hub, and her presentation is titled Visualizing Survey Results from 400,000 people in 29 countries for public use. So Sarah, if you could please unmute, and I think Justine's going to share your slides.
Wonderful. Thank you so much. It's great to be here today. I'm Sarah Jones. I'm the co-creator, along with many others, of COVIDDataHub.com, which is now the world's most extensive cross-country COVID-19 health behavior tracker. If you can advance the slide, you'll see our team that is tackling this on a daily basis. Myself, along with Melanie Lees, of course, the director of the BDAU, and Roberto Fernandez Crespo, also of the BDAU, and Gianluca Fontana. We, the survey, the development of the content was actually until recently overseen by Hutan as our PI, and now the PI is Professor Jeff Sachs of the Center for Sustainable Development. All the data comes from YouGov, and I'll tell you a little bit more about what that data looks like in a moment. But now, when I was thinking about what to share today, something that James just mentioned is really important. The collaboration effort and the immediate group effort and availability of resource that happened in March, not only inside IGHI, but around the world, was astonishing. And in March, when lockdown looked very imminent, and epidemiologists at Imperial in particular were leading the calculation of R rates, virus reproduction, I had this idea that if epidemiologists could track health behaviors at a population level in many countries, we might be able to figure out which NPIs, which non-pharmaceutical interventions, and which health behaviors, protective or preventative, were working best. And of course, in my mind, I was imagining some sort of gigantic logistic regression probably. And that if we could figure that out, that we could reinforce the NPIs that work and eliminate those that don't work. So I contacted some old friends to ask if they could help. The founder of YouGov, Stephen Shakespeare, and the head of special projects there, Marcus Roberts, they've always been generous supporters of the mental health research that I do that benefits the Royal Foundation of the Duke and Duchess of Cambridge and their charity partners. So I asked them if they thought YouGov could help. They asked how, and I asked very sheepishly, can you give away some data? And they said, well, what do you need? And that's how this project was born. It was Melanie's idea and Roberto's idea to build a public dashboard with data for scientists, for the research community, and for the public. And I credit Gianluca with the novel idea that perhaps one way IGHI could contribute to public health wouldn't just be coming up with all the policy answers, but instead facilitating understanding of what's happening on the world stage for a very wide range of experts, ensuring that they have access to that data as well. And if you could advance to the next slide. As James was just discussing, we have an enormous and interesting collaboration of experts. We started building up a global survey. I started to gather up urgent scientific questions from epidemiologists, public health experts like Helen Ward, Neil Ferguson's team, Ben Lambert, Christina Atchison. And we took sort of a bold decision to focus on behaviors, health behaviors, rather than just on attitudes, or rather than doing both. We decided to look at the what and not the why. Now, we've since evolved our thinking a bit on that, but at the outset, modeling the NPIs, how to slow down the R rate was primarily what we were thinking about. So we've been visualizing the data on for the public on COVIDDataHub.com since the beginning, and offering the data for download on GitHub. And each person who has been involved in this has played a really important and pivotal role. And again, there's a very coordinated collaboration in every sense of the word here. YouGov, of course, has been collecting the data for us, and that was being done pro bono up until the end of September, and they're posting it to GitHub. But this quickly caught the attention of other researchers, and our first close collaborators were John Hallowell, Jeff Sachs, and Jan-Emmanuel Deneuve of the World Happiness Report. They brought along with them a very wide range of expertise and colleagues, Dr. Laura Acton, Dr. Shun Wang, and Dr. Haifeng Huang. They're a diverse and dynamic team of optimists, happiness experts, well-being, life satisfaction, data modeling researchers, and one or two of them might also be known for their expertise in economics or being a best-selling author. We are also closely collaborating on mental health, specifically depression and anxiety, with Shekhar Saxena at the Chan School at Harvard and his colleagues, Bizu Galai, Katie Pintro, and drawing on the expertise from Irene Kutamanu, Reza Drukvandia on statistical methods. For policy, we went straight to the experts on COVID NPIs, non-pharmaceutical interventions, and we're working closely with Thomas Hale and Anna Petherick on how to make all the data that we collect talk better to the data that they collect. You can advance to the next slide, please. So who are our co-contributors? We started by casting a net inside of Imperial, and we've been able, with our collaborators, to consult with a really wide range of people about what is necessary to know. We visualize all of this on coviddatahub.com on the dashboard, and we also issue reports every week on key findings, chiefly on cross-country comparison. We've done special reports on face mask wearing and vaccines for the WHO behavioral risk team and the technical team. We've also done self-isolation reports, life satisfaction reports. And questions have come and concepts have come from all of these partners here, including the WHO, from the vaccines team and the behavioral risk team, from the World Happiness Report team and the UNSDSN, the Blavatnik team of the Oxford Tracker, China CDC, and of course some of our internal colleagues at Imperial. And the next slide, please. So how do we know that we're making a policy impact? Well, we know this because our collaborating partners, or those we are in touch with, are some of the key policymakers and thinkers in the world who are using our data, collaborating with us to shape our data so that they can shape their own understanding and responses to the pandemic. So for example, the UNSDSN, China CDC, WHO, the IMF, the ECB, the European Central Bank, the Bank of England, and even our own UK government as well. And the next slide, please. So what are we tracking and displaying on coviddatahub.com? Chiefly, we're tracking health behaviors, hand washing, social distancing, taking public transport. We've surveyed about 500,000 people in 29 countries since the last week of March, and now due to funding constraints, we track about 15 countries. Now, thanks to the expertise of our collaboration partners, we've also started adding attitudes based on what our expert collaborators believe is important, for example, and current. And YouGov also posts this data on the website we run from GitHub for us. And the next slide, please. So this is an example of one of the reports. We've issued about 30 of them, and you can download them from the ICL website. And they provide a high-level roundup of some of the data points. And there's the URL there on the screen of where you can find these reports. And the next slide, please. Interestingly, it's not just policymakers that we have been reaching with this data. One of the interesting things that we found is that over 500 articles have been written using the data, showing that our impact isn't just on policymakers, but also has been very much on the public as well, to shape understanding of some of the cross-cultural differences between reactions to COVID. The next slide, please. So Melanie Leese and her team write these reports every week and publish them. And this is a recent report about self-isolation. And the findings included that about 78% of respondents reported that they would be either very willing or somewhat willing to self-isolate if they were advised to do so by a healthcare professional or by a public health authority. Now, interestingly, Australia and Canada had the greatest percentage of survey participants say that they were very or somewhat willing. On the other hand, Japan and Germany had the greatest percentage of those who said they would be very or somewhat unwilling to self-isolate in a situation. Now, the Cantril ladder is a proxy for life satisfaction. This is a tracker that is provided by the World Happiness Report team. Life satisfaction is a very powerful measure of the quality of people's lives, and the annual World Happiness Report attributes the differences over time and between countries to good health, to income, the quality of their social environment. And these factors are changing under COVID-19, often in ways we have never experienced before. And so the life satisfaction data collected regularly as the pandemic evolves in each of the surveyed countries provides a very valuable barometer, a reading of life under COVID-19, and it reflects each country's institutions and policies. And unfortunately, what you will see is that the UK is third from the right of those dots and is almost at the bottom of the range of countries that we surveyed recently in terms of life satisfaction. And finally, we have everyone that you've heard before to thank for this, including our friends Nikita and Justine, who have tirelessly been helping us communicate this extensive information, reports, data set to the world. A huge thank you, of course, to YouGov and to Stephen Shakespeare and Marcus Roberts, Gavin Ellison, Alex McIntosh, Chris Curtis, Iron Nolse, for having worked so hard in their free time and in their working time to make this happen for IGHI and for all of us. And also to Sharon, Lenny, Alice, Steve, and volunteers from the team that put together the graphics for our reports that make them look like something we can actually digest instead of make us cross-eyed. You can find all of the data visualized at coviddatahub.com. We also have a number of private dashboards that we use with our collaborators, and Roberto and Melanie are responsible for producing this incredible visualization efforts. And that's all I have for you today. Thank you so much for listening, and I hope that you'll get in touch if you are at all interested in using the data, exploring it, or you would find any of this useful for your collaborators.
Thank you so much, Sarah. That was a really lovely presentation. If you have any questions for Sarah, James, or Fahad, please, now is the time to put them in the chat, and then I can put them across to them. We had some lovely comments come in saying such incredible work, so inspiring. We had a question come in quite early for you, Fahad, from Lindsay Dewar, who says, did you include any public involvement in your study, whether it's in the design on the product or throughout the research process?
Hi, we didn't, unfortunately. The reason for that is when this trial was being set up, we were in a bit of a rush to get everything off the ground, up and running. And given that lockdown had just kicked in for the first wave, we found it quite difficult to arrange anything else. Certainly, as I said, this data was to inform future trial designs. So when we eventually finalize the large trial that we want to do, at that stage we'll certainly be using not only this pilot data, but also be getting some PPIE then.
Thank you, Fahad. I guess one of the points that I wanted to raise is that it's quite clear from all three presentations that these innovations have come about really rapidly and, have taken some speed to get on board. Positively during the pandemic, these innovations, it's meant that these projects have been accelerated. We're doing things faster than we could have been. But how can we ensure that research standards and quality and patient safety aren't compromised when we're setting up these projects so rapidly? James, maybe if I could come to you first, please.
That's a really good question, because one of the most important things that I noticed during COVID was that a lot of the barriers to research came down. So we were able to perform research really at an unprecedented pace and scale that was really liberating and allowed us to perform research that simply just wouldn't have otherwise happened. So there were a lot of good things that happened when some of the brakes came off, but I have to say, for us, at the forefront of our mind, safety was always there. We never sort of stopped taking that into consideration, and there was still clearly a process, right? So, for example, with the HoloLens work, we didn't just introduce it into clinical work environments without addressing patient safety issues around PPE usage and contamination, for example, and also around data governance and data protection. So what we found was that we didn't have to bypass it. When we took those things, for example, to the Chief Information Officer's desk, they were just incredibly responsive because the trust had a core mission. There was just one problem that it had to solve, which was the COVID crisis, and actually everything else had been put to one side. So we found that it just meant that we could do things at scale that wasn't otherwise possible. And actually, patient experience and patient engagement then became very important, because when you're using technology like that at the coalface, patients are interested. They want to know what's going on. And then we started thinking about different and other applications. So yes, it was different to normal. It wasn't something that we abandoned. It still was at the forefront of our minds in design of our experiments, but we were able to execute it just much more efficiently.
Thank you, James. Sarah, coming to you on that point, the COVID Data Hub is an incredible tool. How did you make sure these things weren't compromised?
Well, it's a great question. I found that immediately when we reached out to experts, that they were willing to take part. And I think that one of the most important parts of our process has been ensuring that validated questions are used where possible, to ensure that statistical methods are always taken in consideration when we look for effects, and to have a wide range of experts who we can bounce ideas off of. I think that because we're not dealing in a survey world with the life and death matters that the PanSurg team is dealing with, we have a slightly easier time sleeping at night, perhaps, when we forget to wash our hands. Not that we forget to wash our hands, but for us, I think that, and certainly for the more junior researchers on the team, I think one of the most incredible things that's come out of this is the willingness of people to lend their expertise to those who need it. And I would encourage all to ask, when you are not certain, and ask when you feel there's something at risk, and ask when you think there might be an ethical consideration, because it's really important to make sure that you leave no stone uncovered, and it'll surprise you who will respond when you ask for help.
Thank you, Sarah. And coming to you, Fahad, I mean, the sensor work has been very reactionary, and you've been trying to juggle lots of different things that have been happening, restrictions. What are your thoughts?
Yeah, I think certainly we've had some kind of issues, but I think that's not necessarily related to kind of some of the barriers. I think that's just more having to catch up with ever-changing guidelines, and that's merely because no one really knows what was going on. So everything was reactionary. I think certainly a lot of work has been put forward during COVID times, which, as Mr. Kinross has already said, research barriers were easier to get through. Certainly, we managed to expedite ethics for our work and achieve CMO approval quite quickly, and I think that's come about because of COVID.
Thank you, Fahad. It says, just as long as we know that research done at this rate does not go off without the proper ethical assessment and PPI involvement, and we've also got some other questions coming in. Lots of comments coming in from Clarissa, but it's also about ensuring that we are implementing interventions which are appropriate to those who most affected, but possibly less considered for invited to research. I also wanted to ask about kind of accessibility when it comes to innovation. with these COVID projects, it just seems like the world of innovation has opened up a lot more projects, you know, a lot more cross-disciplinary, and we have, you know, it seems like if it doesn't matter about age or seniority, you know, if you have an idea, a legitimate one, people are all ears. And I think, you know, some of that work, I've definitely seen that in PanSurg. James, like, what is your thought? Has innovation become more accessible?
So when we ran our Aftershock series, which is all freely available online, by the way, if you want to watch those videos or download it, innovation was a theme that constantly came up, and people were talking about the need to innovate. So, for example, if you want to solve our diagnostic backlog, we can't just go back to normal. We have to innovate. We have to do something new. And Mike Farrar, who was the ex chief exec of the NHS Confed, was one of our panelists, and he made the observation that we've always kind of been quite good at understanding what innovation is and at finding these technologies and doing kind of small studies and small trials, but actually we're not so good at really adopting these technologies. And really what we should be learning in the on the other side of COVID is, how do we enable and empower our managers and health leaders to adopt these innovations? How do we give them the skill sets that they really need to bring them into their kind of standard clinical practice? And that really, that's, you know, pretty pertinent if you've got something like you know, medical therapy where there's a decent kind of pipeline, but it's less clear in something like digital healthcare, which is much newer, and the roadmap is kind of less clear. Some managers understand that it's important. They just don't have the skills to really onboard those innovations into their hospital, and we have to help them design new pathways of care or new patient you know, referral patterns, whatever it is, to kind of to fully maximize their value. And so to me, that was quite a key learning.
Thank you, James. Sarah, I think we've got a question for you from Alison. Is there any mileage in using QALYs, which is quality adjusted life years, to assess the impact on the public of lockdown, given the life satisfaction data we have to understand first do not harm impact of lockdown?
Yeah, absolutely. I do think that there is enormous value in that. And I think that one of the things that we've come to realize over the course of several months now is that economists are just as interested in health economists in the health behavior data as epidemiologists are and as other health policymakers are. And that understanding what kind of effects on either the longevity, you know, is, unfortunately, we need to do that in a longitudinal way. And one of the frustrations, of course, about doing 29 cross-sectional surveys every 2 weeks is you're not doing it with the same people. So we have a wealth of variance, for example, in our populations, but we don't have as a great longitudinal set. And I think that to do QALYs properly, you would need to do a very good longitudinal set for that. But I don't disagree that over time, it's going to be one of the arbiters. I think that of all of the health policy literature that I think of as being impactful, it almost always requires an economic measure and an adjusted sort of life year measure to really hit home what the burden is.
Staying with you, Sarah, we've got a question from Clarissa. With regards to this tracker, are there any areas or data that haven't been reported on, which you think would be useful to publish?
Hundreds. Can you come talk to me? Because there is so much in there, and we would love some help with that.
Thank you, Sarah. We also have another question from Raya, who actually, I think this question was directed at you, Sarah, but I think it's applicable to everyone. Mm-hmm. If we twist it a little, can your data information potentially inform governmental and local policies?
I'm going to answer that very carefully. It does. I'll leave it at that. And also, I'm sorry.
Thank you, Sarah. James, can I ask, PanSurg has been doing a lot of research, how are you trying to inform government policies?
So our strategy has been to move towards engaging directly with policymakers. So we've been able to leverage our webinar and aftershock series to do that. So to actually have a direct conversation, that's the first thing. The second thing is to try and drive our output into basically to policy documents. So to try and put it into the language that policymakers read and use. So that's why we created the first aftershock document, because then you have a tool that you can try and put under the noses or use as a lever to speak to the right people in the right places. What has been absolutely amazing to me during this crisis, and what is testament to the department really, actually, in the reach of the department, is that you really can pick up the phone to just about anybody. Like the level of conversations that we've had has really been really, in some ways, quite reassuring and inspiring. That if you really have something to say, you can say it to the right people. So you should have confidence to try and reach out and to make yourself heard. And then the third thing that you have to do is that this might sound flippant and silly, but you've really got to have an engagement strategy, right? You can't just hope to publish something and it to be read. That just doesn't happen anymore in the modern world. So, Nikita, you know this because you've helped us so much, but like we specifically went out of our way to create a social media strategy at the outset and to build out a community of people that were with us on our journey and that contributed to our journey and that kind of, had as much chance to input into what we were doing. So we were talking about patient input before, right? So a lot of what we're doing was directed by our community saying that we've got this problem, we don't know what to do, can you help us? And actively getting involved in our work. And actually that makes the whole thing really enjoyable because you feel like you're not you're on your own. You feel like you're part of something that's much more collaborative, but it's a lot of work. As you know, you did a lot of it. So yeah, those three things I would say are the main things.
Thank you, James. And Fahad, just coming to you, is there any scope for the sensors to be used more widely?
For sure. I mean, sensors already, they're moving into the home environment. People are coming up with smart sensors. In fact, there's a trial due to be launched out on that already, where they're sending people home with kind of smart sensors which tap into for home monitoring. But it can also be used in other ways. So you could use them potentially for those who are undergoing elective procedures. They require now a period of isolation. So you could easily set them home with a sensor during that period and see if they deteriorate beforehand, knowing in advance that their operation might need to be rescheduled or postponed. Similarly, you've got all those individuals who've got respiratory ailments who are most prone for picking up any kind of respiratory infections, not just COVID. So again, these people would be well versed about having some kind of remote home sensing equipment, allowing them to stay out of hospitals, which in itself isn't a very safe place.
Thank you. I think we've come to the end of our forum now, but there's so much that we could still be talking about. There's so much global appetite for collaboration, and innovation has definitely taken off. And I think we had a comment. I'm just going to find it from Vanessa, who said, really interesting and reassuring that so much good work is going on. And there's so much good work going on that we've got a part 2 of this Global Health Forum coming up on the 3rd of December. So please do join us, and we will have 3 speakers with 3 different projects, and they'll be talking about their projects and their experiences of creating those innovations. But I really want to give a big thank you to our 3 speakers who have been very inspiring and given some very quick whistle-stop tours of their project, which have been in the works for a long time. So thank you, James, thank you, Sarah, thank you, Fahad, and thank you to you for attending, and please do join us for our next Global Health Forum. Keep an eye on IGHI's website for more details. Thank you very much and enjoy your evening.
Thank you, Nikita. Thanks for organizing us.
Thank you.
Thank you, Nikita. Thanks, everybody. See you soon.
Bye.